Hello. In this presentation, we will be looking at the case study of a young man named D.B. We will be outlining today the course of occupational therapy with an emphasis on assessing cognitive functioning. So this is our patient. He is a young male aged 26 who is a police officer in his rural community. One day, while walking in his neighborhood, he was struck by a vehicle and was rushed to the hospital. Upon admission to the emergency room, he had a Glasgow Coma Scale score of 6, and records indicate that he was in a coma for approximately 10 days. In addition to this TBI, DB also sustained fractures in both legs, a tibia-fibula fracture on the right and fracture of the femur on the left. Due to the implications of possible cognitive and physical impairments, DB was certainly a candidate for occupational therapy. So in the hospital, he participated in inpatient rehab for 3 weeks. And then at approximately 3 months post-TBI, DB was referred to an outpatient occupational therapist who assessed his readiness for independent living. To review DB's case, we have constructed a concept map to better illustrate each phase of his occupational therapy. Here is a bird's eye view of our concept map. As you can see, each section is color coordinated. We will begin by discussing DB's occupational profile, then move on to the problem areas. We will then discuss goals that an OT might set. We will look at the causes of his problem. We will then look at the OT approach and frame of reference, intervention activities an OT might perform, and finally, service delivery. So let's get started.
DB is a 26-year-old male diagnosed with a traumatic brain injury due to a pedestrian auto accident. He was referred for outpatient rehab for occupational therapy 3 months post-TBI to assess his readiness for independent living. He has no prior medical history or concerns, and his prior level of function was totally independent, as he was a healthy community police officer at the time of his injury. According to his social history, he had a recent breakup with his girlfriend, but his great relationship with his friends and brother have helped him cope with the breakup. Before his injury, he was living on the 2nd floor of his apartment complex. It was very cluttered with boxes and cords askew, so he moved in with his brother post-injury so he would be in a safer environment and his brother could take care of him. In his free time, he enjoys fishing, hunting, and playing baseball. Medications he is currently taking are over-the-counter, such as Tylenol and ibuprofen, as well as Vicodin, heparin, and Zoloft for pain and sleep aid. He's allergic to peanuts and penicillin. His cognitive strengths include orientation, comprehension, naming, and construction, while his weaknesses are mild impairments in similarities, judgment, calculations, repetition, and mild to moderate impairments in attention and memory. The OT's focus in this is to gain insight in his level of occupational function through various assessments. Before starting therapy, the OT should consider insurance considerations and ensure that therapy sessions will be covered, and if so, for how long, meaning how many days or hours in a week. Once all of the pragmatic aspects have been taken care of, we move on to the evaluation aspect of therapy. The occupational performance areas affected most for DB were in ADLs, IADLs, memory, and awareness. As an OT, we would assess his priorities and awareness, safety, and identify his cognitive strengths and weaknesses to aid in his daily living activities. We would assess these factors by using certain assessments such as the COPM, EFPT, and Cognostat, and SAFER for a home assessment. We would recommend therapy 2 times a week for 1 hour each session. DB's treatment plan would include working on cognitive skills involving higher order thinking, safety when performing ADLs and IADLs, and increasing his stamina to perform activities.
So the problem areas of occupation, we'll start with ADLs, lower body dressing due to fatigue. Also functional mobility is also due to fatigue. Personal hygiene and grooming, he has problems with initiation, so that affects his grooming. And then IADLs are health management and community mobility. For health management, he needs help with medication routines due to impairment in memory. And community mobility, he really wants to get back to driving, and he can't do that due to impairments in attention and judgment. His social participation is another problem area, especially with his peers due to his recent breakup. Also, decreased community mobility. It's difficult to get out of his house and move in the community, and also moving out of his brother's apartment. His leisure participation is also affected, so we want to work on hunting and baseball due to his problems with initiation of movement for pulling the trigger and then swinging the bat. And then for work, employment seeking, he was previously a police officer, so if he can no longer do that job, we need to find a job that he could do. And then job performance, he may have difficulties due to impairment in judgment and attention.
So, based upon the areas of occupation that the occupational therapist sees concerns in, and based on the causes of problem, which we will review next, the OT will make some goals for DB. These are just two of the possible goals that he or she may make. So the first would be that DB will follow through on intended tasks with modified independence at least 85% of the time through the use of external memory aids within 6 weeks. So this will help him get back to his independent living. Some short-term goals that would support this are that DB will promptly refer to his medication checklist following his phone's alarm 50% of the time within 2 weeks. The next is DB will retrieve a glass of water and intake the pills for the appropriate day using a checklist and pill box with 3 verbal cues within 3 weeks. Finally, DB will maintain attention throughout home management tasks by completing them fully 50% of the time with supervision within 4 weeks. The next long-term goal we have here is one that concerns his area of occupation of work. So it is that DB will improve his attention to detail to have an error rate of less than 10% on pencil paper tasks without verbal cues within 8 weeks in order to more fully participate in IADL and work occupations. A short-term goal would be that DB will perform 6 simple budget calculations with an error rate of less than 50% with 6 verbal cues within 3 weeks. DB will complete 1 driving offense ticket with an error rate of less than 33% with 2 verbal cues within 4 weeks. Then finally, DB will then complete 2 driving offense tickets with an error rate of less than 50% in a noisy environment within 6 weeks.
Causes of problem. DB's problems can be attributed to his deficits in particular areas. In performance skills, DB has difficulty with process skills of heeds, initiates, continues, and sequencing as noticed by the therapist during the Cognostat evaluation. In motor skills, DB has difficulty with endurance, reaching, bending, as is evident in his lower extremity dressing. Under performance patterns, the routines that have been disrupted in DB's life are difficulty adhering to medication management and schedule, ADL dressing due to lower extremity fractures, and functional mobility. Some habits are impaired because of cognizant deficits, such as safety issues like remembering to turn off the stove. His role is currently that of a disabled police officer going to rehab to return to independent living. Client factors affected: body functions, particularly specific mental functions of judgment, metacognition, executive function, similarities, calculations, repetition, attention, short-term and working memory, thought, awareness versus reality and delusions, motivation, problem-solving, joint range of motion, strength, muscle power, and muscle endurance. Body structures affected are his brain, lower left extremity, the femur, and the right left extremity, tibia, and the fibula. Activity demands required actions and performance skills to complete ADLs necessary to live independently. Required body functions is a cognitive level. Relevance and importance to client. Driving car equates with independence. The social demands are expectations from brother to complete rehab for independent living His context and environment, his personal context, he's a 26-year-old police officer living with a brother while in rehab, and his physical environment is living in his brother's home.
The approach we will be using with DB is the establish restore. It is important that we restore any skill, role, habit, or occupation that has been lost or impaired. The most ideal frame of reference to use with DB is the neurofunctional. This is used with clients who have a severe cognitive deficit following a brain injury. The objective is to retrain the lost skills through compensatory techniques or errorless learning and repetitive practice using the same task and subcomponents of the task within the same environment. For the intervention, the emphasis is on the use of task-specific training or repetition of a task routine in natural context to develop habits and functional behavior routines. The first one would be to reestablish a routine to facilitate the activity of taking medications consistently using checklists and an alarm watch. This would focus on medication management, skill habit training, and compensate for memory problems. The second one would be to engage DB in pencil paper tasks, budget forms, driving offense tickets under different conditions such as noisy and quiet, morning, evening, crowded room and empty room, and inside and outside. This would focus on attention, concentration, task environment modification, and cognitive stimulation. And last, it would be to provide DB with a pocket-sized week-at-a-glance planner and have him write down all his routines and tasks, such as taking medications, paying bills, self-care, housekeeping tasks, and homework assignments. And this would help with note-taking initiation, increase memory and efficiency. It would reduce verbal cues, and it would make sure his homework is completed. For the service delivery, it would be by an OT or a CODA. It can be in his kitchen, room, front yard, or in the street, and his TV room to include noise. It would preferably be in the mornings, and it would be 2 to 3 times weekly for 60-minute sessions, and it would be for a total of 8 weeks.
That concludes our presentation. Thank you very much for your attention.